Good afternoon, ladies and gentlemen. It's the COLOCON conference that we are going to have it today with the auspices of the Association of Colorectal Surgeons of Sri Lanka. And since we are already late 10 minutes, without any further ado, let me introduce the panelist, Professor Ishan Soisa, who is a colorectal surgeon, general surgeon with special interest in colorectal surgeon, Professor Pramod Chandrasinghe, senior lecturer and professor at North Colombo Medical College, Dr. Nisanka Jayawardena, senior consultant surgeon, past president of the College of Surgeons, currently attached to National Hospital of Sri Lanka, Dr. Mahanama Gunasekara, senior consultant surgeon, past president of the College of Surgeons, currently attached to National Hospital, and myself, Duminda Ariyaratne, currently attached to National Hospital. Without much further ado, we have a list of panelists who are highly eminent personalities, very well known. They are joining us.
Okay, start. It will come.
What's going to happen now?
They will restart the session then.
Yeah.
You can start.
Good afternoon, ladies and gentlemen. It is my great pleasure to welcome you all to COLOCON 2023, the inaugural conference of the Sri Lankan Association of Colorectal Surgeons. To deliver the welcome address, I would like to invite the president of the association, Dr. Vasantha Wijayanayake, who is a consultant colorectal surgeon at the Faculty of Medicine, Kotolawa Defence University.
Very good afternoon to you all, council members, delegates, distinguished speakers with us from various parts of the globe, invitees, ladies and gentlemen. It is with great pleasure and pride that I welcome you all to the inaugural Congress of the Sri Lankan Association of Colorectal Surgeons, COLOCON 2023. Colorectal surgery is one of the most ancient subspecialties in surgery, being able to trace its roots back to 3150 BC to the land of pharaohs. From the good old days of the scalpel of Susruta to modern day robotic and laser scalpel, colorectal surgery has been an integral part of general surgery, instrumental in developing surgical care in terms of research, guidelines, protocols, techniques, and equipment. Even though Sri Lanka recognized colorectal surgery as a specialty relatively late, the introduction of colorectal interest in general surgery training program by PGIM, Postgraduate Institute of Medicine, gave its due recognition. After much deliberation in what was a pivotal moment in the career of Sri Lankan surgeons, Sri Lankan Association of Colorectal Surgeons, SLACS, was launched in 2021. The SLACS was launched with the objective to improve the quality of colorectal training, encourage quality research in colorectal diseases, and to formulate national guidelines in the hope of providing top-notch and state-of-the-art care to patients. As the founder president of this esteemed association, I have been fortunate to witness the feats achieved by the association in the advancement of colorectal care in Sri Lanka. Today, we are fortunate enough to host our first ever Congress in conjugation with Sri Lanka Surgical Congress, making history yet again in the annals of surgery in Sri Lanka. We have an interesting program lined up today with eminent speakers joining us from all parts of the world to share their valuable knowledge on the management of surgical conditions as well as the future of colorectal surgery. I'm also pleased to announce the launch of SLACS website, which will be unveiled during the Congress. A lot of interesting things happening today, so stay tuned. I hope that this Congress sparks innovative discussions as well as interest in the colorectal field. Countless hours of hard work needs to be put in to pull off an event of this magnitude. So thank you to all those both behind the curtain and on stage for making this day possible. Thank you and have a stimulating afternoon. Thank you, everyone.
Thank you, sir. Today's session will be divided into two components, a focus on the colon, which will be pre-lunch, and a subsequent focus on the rectum, it will be post-lunch. For our first focus on the colon, we have an esteemed panel of professionals. So I would like to introduce them. So we have Professor Ishan D'Souza, who is a professor in surgery at the Faculty of Medicine, University of Colombo. Dr. Duminda Aryaratna, consultant surgeon at National Hospital of Sri Lanka. Dr. Sumudu Kumarage, consultant colorectal surgeon at the Faculty of Medicine, University of California. Dr. Nisanka Jayawardena, consultant surgeon at National Hospital of Sri Lanka. And Dr. Mahanama Gunasekara, consultant surgeon at National Hospital Sri Lanka.
Thank you for that introduction. We will be starting the 4 presentations, and we'll start in the first one, which the presenter would join us live on Zoom, on live virtual platform. The resource person is Dr. Rodrigo Perez, who is a consultant colorectal surgeon, University of Sao Paulo, Brazil. He's going to talk us today about neoadjuvant therapy in colon cancer, a new paradigm.
Hi, everyone. First of all, I want to thank the organizing committee for the kind invitation to speak. It's a pleasure for me to be here, and I honestly want to have the opportunity to visit your beautiful country anytime soon. Today, I'm going to speak about the next paradigm shift in the management of colorectal cancer. It has nothing to do with rectal cancer, but colon cancer. The fact is, very recently, patients with a tumor like this and a right colon cancer like this, and you can see the CT scans showing a thickening of the bowel wall at the site of the cecum. So, and a patient like this would probably go straight forward to radical surgery. And this patient would probably undergo radical surgery, meaning a D2 or even a D3 lymphadenectomy, and then selective adjuvant chemotherapy. Now, I mean selective adjuvant chemotherapy, meaning that depending on the final pathological stage, we would give a combination of FOLFOX for patients with stage 3, or even only 5-FU-based chemotherapy for patients with high-risk stage 2 disease. This means we would be able to adapt exact systemic therapy based on final pathological stage. Now, the paradigm shift is quite interesting here. Instead of giving selective adjuvant chemotherapy, when we think about neoadjuvant treatment of patients with colon cancer, we are giving compulsory neoadjuvant chemotherapy. Now, when I say compulsory, I mean all high-risk stage 2 and all stage 3 disease, based on radiological staging, will receive combination 5-FU and oxaliplatin-based chemotherapy, everyone. Now, the idea here is to tackle micrometastatic disease up front. That's number one. And number two is to increase compliance. Now, a lot of patients who undergo colon surgery end up not receiving adjuvant chemotherapy, not because of final pathological staging, but because of complications. So the idea is twofold here. First, tackle micrometastatic disease up front, and number two, increase compliance. Now, studies have been designed to show this primary endpoint, that tackling micrometastatic disease could actually improve the survival of these patients. So a trial was designed, and I'm sure many of you are acquainted with this trial. This is the Foxtrot trial that was designed a long time ago. And you can see the trial design here is pretty straightforward. Patients ended up receiving, in total, 24 weeks of chemotherapy. In the experimental arm, patients received 6 weeks of those 24 weeks before radical surgery, as opposed to the straightforward surgery first, followed then by 24 weeks of combination chemotherapy. Now, the preliminary data was quite attractive and quite exciting. Why? Because patients who underwent neoadjuvant chemotherapy before surgery, so those 6 weeks of FOLFOX up front, they had more R0 resections, they had more N0 disease, while the number of harvested nodes were pretty much the same. So apparently there was a benefit when looking at the pathological outcomes. So quite interesting, and everybody was excited that this would translate into survival benefit. And to tell you the truth, it actually did. It took a very long time. You can see here this update of the Foxtrot trial was published nearly 10 years after the original preliminary data, and it finally did show a statistically significant disease-related recurrence. And you can see here the 2-year recurrence difference is Foxtrot, which is the IDEA trial. Now, the IDEA trial looked at 6 different prospectively randomized trials, and they compared in the non-inferiority design the difference between 3 months, 12 weeks, could have received 12 weeks only. So perhaps the Foxtrot would have to be redesigned now for a 12-week duration of chemotherapy instead of the actually performed 24 weeks. When we look at this same data in the rectal cancer setting, it's quite similar. This is an interesting timing trial that was recently published. Now, the timing trial was the comparison of patients who underwent different consolidation regimens of chemotherapy. And you can see here that the only group that did worse in terms of disease-free survival were those patients who actually had no consolidation chemotherapy. The 3 groups that are all together on top of these survival curves are the ones who received 2 cycles, 4 cycles, or 6 cycles of chemotherapy. So 2, 4, 6 made no difference in terms of disease-free survival. The only group that did worse was the one who had no additional cycles of chemotherapy in the consolidation period. Meaning again that adjuvant chemotherapy of 24 weeks may be too little, too much. The third point is the actual publication of the ctDNA guided study in patients with colon cancer, because now patients who have stage 2 colon cancer may not require compulsory chemotherapy. This study looked at the ctDNA, so circulating tumor DNA in the peripheral blood, to guide treatment in patients with stage 2 colon cancer. And they actually found that patients that were managed ctDNA guided avoided unnecessary chemotherapy in the vast majority of patients who had ctDNA negative cancers with no compromise in disease-free survival. So stage 3 probably doesn't need 24 weeks, and stage 2, despite being high risk, probably also don't even need chemotherapy adjuvantly, because if they have ctDNA negative, they probably can avoid altogether systemic chemotherapy. So perhaps when we think about it, the new standard of giving chemotherapy compulsory to all stage 2 high risk or stage 3 colon cancer, they have some problems, and the pitfalls are CT is not accurate enough. Number 2, you have to admit a significant amount of overtreatment of patients. Probably 24 weeks is already too much. And with the ability of selecting patients based on the circulating tumor DNA positivity or negativity may actually influence those results. Well, if this was not sufficiently controversial, then in ASCO 2023, the Scandinavian group published their outcomes with a similar design, or similar trial design. So they did a very, very similar trial looking at arm A, standard surgery followed by adjuvant chemotherapy based on TMN. There was no also ctDNA guided management. And the experimental arm, very similar to the Foxtrot study, where patients received chemotherapy up front. Interesting, the difference here is they didn't use the 24 weeks of chemotherapy. They had 3 cycles of Kpox only, and the primary endpoint was disease-free survival. Now, when you look at the data, it's quite interesting. When we think about compliance, patients who underwent chemotherapy first actually had lesser number of cycles being delivered in total. Patients who underwent upfront surgery required more frequently and probably increased the amount of cycles. Now, what's more important here is that the primary endpoint was a negative study. There were absolutely no differences in terms of disease-free survival or overall survival between of the groups. So there were no differences in terms of disease-free survival, in contrary to what was seen with the Foxtrot study. So at the end of the day, we have now a problem with the neoadjuvant chemotherapy because, number one, we don't have consistent disease-free survival benefit yet. At least we have one study that shows a benefit and the other that does not. Maybe for patients at high risk for R1 resections, because giving chemotherapy up front did result in a high rate of R0 specimens. Maybe for patients who require rehabilitation because they're not ready for surgery yet. But there's probably no need for 20 weeks of chemotherapy altogether. We have to admit significant overtreatment, and we cannot stratify patients based on ctDNA as we currently have the data available. So at the end of the day, I think we're not there yet in terms of giving all of our patients neoadjuvant chemotherapy until we have a robust data to support that there is an actual clinically relevant benefit to these patients. I hope this is interesting to you, and I'll be happy to take any questions. Thank you very much.
I thank very much to Dr. Rodrigo Perez for his excellent lecture. Unfortunately, he's not available to answer your questions. So therefore, we would like to move on to the next one. This will be, the next lecture will be delivered as a pre-record event by Dr. Danilo Miskovick from the St. Mark's Hospital, London. He would talk to us on complete mesocolic excision from concept to practice. We move on neoadjuvant therapy to surgical arena. To Mr. Danilo Miskovick.
Hello everybody, and thank you very much for having me. I'm sorry I can't be there in person, but I am sure it will be a fantastic conference. My name is Danilo Miskovick. I am a surgeon at St. Mark's Hospital in London, and I was asked to speak about complete mesocolic excision, or CME, from concept to practice. Now, when we look at right colon cancers versus left-sided colon cancers, there seem to be some differences. And one of the major differences that we can observe is that there is a different type of biology. To summarize this very briefly and very kind of as an overview, the right-sided cancers have bad biology compared to the left-sided cancers. As you can see here in this example, showing that bad biology leads to, for example, insensitivity to chemotherapy, but also that these cancers can be more aggressive and can have worse outcomes itself. And we can actually show this difference, and this is just one of many studies. This is done by Nicola Hodges, one of my colleagues at St. Mark's, who was looking at outcomes of colon cancers from using different databases in England, and looking at all the operations that have been done over a 5-year period from 2000 to 2015, and following these patients up. And what she found was that there were differences in overall survival, looking at right colon cancers compared to left colon cancers, or rectum, which were almost identical. So you can see here the blue line represent the right colon cancers. And when you look at the more advanced stages, so stage 3 cancers, you can see that this difference becomes much more obvious, with almost a 10% survival difference between right-sided cancers and left-sided cancers, even when adjusted for all other factors such as stage and age and comorbidities, etc. So right colon cancers are doing worse. What is also interesting to observe is that when we look at how many lymph nodes have been collected, the difference, so all the different types of cancers are getting better the more lymph nodes that were collected in the specimen. But what is also interesting to see is that the difference between the right and the left seems to disappear. So is it possible, and that's the question, can we with surgery compensate at least for some of the bad biology that we observe on the right-sided cancers? So is it about the lymph nodes? That's the first question. So is there a therapeutic effect if I remove more lymph nodes, or if the pathologists find more lymph nodes, that we actually, by removing that tissue, that will lead to a better survival? Well, it has been questioned in many ways. And as you might know, very few cancers actually have positive central lymph nodes, or so-called skip metastases, where you have a central lymph node but none of the distal lymph nodes. That's probably only making about 1% of all the cancers that have that. But nevertheless, this may play a role, but it's probably not even that important that we take individual lymph nodes out. Another theory that has been highlighted is there stage migration? So is it possible that if we don't observe many lymph nodes, we may miss some that were positive, and then these patients don't get chemotherapy, for example. So they have not adequate treatment, and that's why they do worse. And that doesn't seem to be really a case, because you can see in many studies it has been shown that once we go beyond about 12 lymph nodes, there don't seem to be any difference anymore in staging. So 12 lymph nodes seem to be representative enough to give you a good staging. But are they good enough to get you a better outcome? That seems to be the question here. Now, when we look at lymph node numbers, we can see that if you take a lot of lymph nodes, so we see here the top line in both graphs, is more than 40 or more than 35 lymph nodes. If that many lymph nodes are removed, they do actually do better. So they survive better. So again, that seems to support the first theory. If you take all these lymph nodes out, maybe they do better. However, the interesting thing is, even when these lymph nodes are all negative, if you take out more lymph nodes, or if you detect more lymph nodes in the specimen, they seem to do better. Now that doesn't make any sense, does it? Well, maybe it makes sense, because there is another theory, and that is that there is the lymph nodes are nothing else but representative for how your immune system is reacting to the tumor. And the theory is that if you have many lymph nodes, that is probably a good sign, because it seems that your immune system is doing something against the cancer. And that's why these cancers have generally a better outcome. So just the fact that there are many lymph nodes around, even if they are negative, they are not non-cancerous, may be a good sign, because that is an expression of your immune system fighting the cancer. But all these observations remain slightly unclear. And what it comes down to is we don't really know. Understanding what is happening and why these different lymph nodes, or taking out more tissue or less tissue, make a difference in an operation, we don't really understand. What we do know is, if we do operate more radically, it makes a difference in survival. And one of the first one who was showing this very impressively was Anders Bertelsen from Denmark, who could match his patients one-to-one and comparing them between two different institutions where surgery was performed in a different way with comparable populations. And he could see a significant increase in survival for those who have been operated with complete mesocholic excision, so with a more radical approach than the traditional right hemicolectomy. And these differences are, again, quite staggering and somewhat difficult to understand as well, because he could show improvement throughout all the stages, apart from stage 1. Again, maybe there is some impact here of biology, but this is, if you think, a chemotherapy trial that can show such a difference, would be revolutionary. Of course, these are not randomized controlled studies, but they are as good as it gets in surgery, that you're really comparing similar populations treated by different surgeons who are using different approaches. Another study more recently that has been criticized in many ways is this German study, where they were looking similarly at overall survival between not two different approaches, but what they were doing, they were looking at more complete specimens compared to less complete specimens. And they could show differences as well between a CME approach and a non-CME approach. But they couldn't really prove significant difference. And the editor of the British Journal of Surgery kind of, let's say, forced them to come to a conclusion which is really not so much supported by people who are working in this field. And the conclusion was that it makes no difference, which is not really what there is. There is a difference. It might not be reaching significance in terms of statistics, but if you just think about this is the same graph just for the stage 3 cancers. Do you really want to be on the blue line, or would you rather be on the red line? Well, I am pretty sure for myself where I want to be. And I think all of that is especially important in the context of risk as well. And I don't have much time today to explain all of that, but studies have shown again and again that there is no real difference in significant complications intraoperatively or postoperatively that are making that much of a difference. Yes, there have been studies showing that there is slightly more rate of central vascular injuries, but even those patients did not have a consequence of that was changing their lives in any way. Now, I want to come away a little bit from the evidence here and more to what that concept really means in practice. So CME is a concept, and I explain what that concept is, but I also want to show how that translates into practice. So the concept is that there are three key principles of a CME. One is that we do appropriate longitudinal dissection. So we resect bile proximal and distal to the tumor. There is central dissection, and that's what is often associated with CME, but that's just about part of it, which is basically central vascular ligation, removing the central mesenteric portion. But also then circumferential, so staying in the embryologic plane, in the so-called CME plane, is as important as everything else. So there are really three principles that we follow, and that is the concept of CME. It's not just about taking the central vascular pedicle. When we do CME, we usually do this robotically. This is just a quick view of our theatre, of how it looks. We use a Da Vinci XI system with double console and table motion. And we usually dock it in a way that we are working from bottom up. And that's very similar to the laparoscopic approach as well, that we are trying to really see and focus our instruments on the mesenteric vessels, because that's where the bulk of the dissection is actually happening. So these are the port positions that we're using in the robot. 4 ports basically horizontally between the 2 anterior superior spines. And then we have a straight view onto the mesenteric vessels. But as I said, it's not just about the vessels, it's about everything else as well. And to understand that better, we're using this open book model, which basically just is a different way of looking at anatomy in an easy way. And the first step that we do is really that we go in on the retroperitoneal page. So we're lifting up the terminal ileum, we're lifting up the cecum, and we are entering the mesocolic plane from behind onto the duodenum and onto the pancreas and open up everything. So it's quite difficult to understand the anatomy around there, and we've done some cadaveric work as well. I recommend this paper by Thilo Wedel, an anatomist from Germany, who we've worked together to redefine these planes, and it's really quite mind-blowing how anatomy is still very unknown in a certain way, because we found things that we were able to describe in different ways and in a maybe surgically more logical way where we go. So this is where we enter. We are behind everything, so we can see the duodenum there. And as we're opening the planes up, we're basically retroperitoneal now. So we're behind the parietal peritoneum, and we're almost cockerizing the duodenum a bit. And then we go in front of the duodenum, so we have to actively break through another plane in order to be in front of the duodenum and in front of the pancreas. So that's really the first step, so to dissect that plane from behind, and then we leave a little swab there for the next step. And the next step is then that we bring down that retroperitoneal page, so that we bring the small bowel down, and we're now looking onto the mesentery, so straight onto the vessels of the mesentery. And as you know, the vessels are anatomically complex on that side and individually different. So each patient seems to have a slightly different anatomy, and that's something that we are trying to use when we operate. So what we are usually doing is that we don't just look at the scans, but we are also trying to 3-dimensionally reconstruct the scans. So we're using the normal CT staging scans and create a 3D model of the vessels so that we understand them better. This is what it usually looks like. So we have a model like this where we can fade in and fade out different aspects of the anatomy, and we really use these models then during the operation because they can guide us during the operation. So when we look in the console of the robot, this is the picture that we see. We can see them side by side, so we see the model below, and we kind of orientate the model in a way that the operation situs is looking like, and then we can really identify vessels much easier, and we know where they are and understand the anatomy as we go along.
it's a bit like rain stopping play in the Asia Cup. They are assuring us that it will be okay in a few minutes.
Good. It's not, so it's not my end.
So I'll show you here a couple of examples. So this is a more or less complex Henle trunk dissection with lots of veins that you see. There's a gastroepiploic vein coming down. Then we have, when we remove the arteries here, we can also see a separate middle colic vein. We can see a Henle trunk with a right colic vein. And we can see another separate middle colic vein going into the splenic vein. So you see here clips. The clips have been put onto the middle colic vein and onto the right colic vein. This is an extended right hemicolectomy. That's why we take them both. And now we're looking onto the superior mesenteric vein. And you can see here the first vein coming up. That's the middle colic vein. That's the one that is right there in front of us. And that's only part of the middle colic vein system. That's only a right branch probably, because we know there's another branch further to the left. And then you can see here how we take that and clip it. And you can just see below that there is the Henle trunk that feeds into the gastroepiploic vein and into a right colic vein and into a pancreatic vein. So it's a typical Henle trunk with all the different branches. And as you see, we're going along all these branches with the guide of the 3D model, and we can identify the individual branches. Again, here that's the right colic vein or superior right colic vein that we have to take as well. So that's just an example of how we can use these models. Eventually, we have to release the lateral and the superior side. I'm not going too much into the details of that to complete the dissection. And ultimately, we end up with a transected terminal ileum and a transected transverse colon, and we use an intracorporal anastomosis to join them all up again. So this is the practice, and you can see how all these principles that I explained at the beginning of my talk translate into practice. And that's very much a standard approach for us for all right colon cancers, independent of stages and independent of the patients. The only differences, or the only exceptions rather, are really frail patients, kind of palliative cases, or patients who are otherwise extremely old or frail, where we may do a less radical approach. But to be honest, time-wise and morbidity-wise, it doesn't really make much of a difference, whatever approach we use. So this is very much our gold standard approach. So, in other words, CME is the concept, anatomy is the principle, and for us, robots are an enabler, but by all means, it doesn't mean that robotics is the only way of doing this operation. It can be done laparoscopically or, of course, open. That's self-explanatory. But I hope that I could show you that all the detail really lies in the anatomy, and understanding that anatomy is ultimately the basis for everything that we do in these operations. So thank you very much for your attention, and I hope you have a great day.
Thank you for that excellent talk. I believe you're available for questions online.
I am. I don't know whether you can hear me or see me.
Is he available? Yeah.
Hello? Can you hear me?
Yeah, yes. Any questions from the audience?
Hello, Danilo, can you hear us?
Yes, I can hear you.
All right. Okay, good. Pramod here. Hi.
Hi, Pramod.
I think you can ask a question. Yes. Hi.
Do you do
Danilo.
all your cases robotically, or do you do some laparoscopically as well?
I think nowadays and for the last 5 years or so, it's all robotic. But before I have done the same thing laparoscopic as well. But it's just in many ways easier and more streamlined. So all my practice is basically robotic nowadays.
Danilo, would you think there's an increased rate of morbidity associated with closed vessel ligations?
I personally don't think so. There is a range of evidence in the literature that there isn't. Having said that, the probably most important paper, which was the first one that reported on short-term outcomes, was by, again, Anders Bertelsen from the Danish series. And they reported significantly, but a small amount of central vein or mesenteric vein injuries, which occurred less in the non-CME group. However, again, I think there were in total 9 patients out of 500. These patients, they did not have any kind of sequelae from that or any consequences from that because it was repaired intraoperatively and they didn't have any long-term issues because of that. In my own practice, I don't think that we are observing that. We are just now looking back, analyzing for the last 5 years if you can see any differences, but so far I don't think that there are any obvious differences in morbidity, neither short-term nor long-term.
Have you observed an increase in disease-free survival rates in your cohort after you took up?
Again, I think, yeah, again, I think this is something we are still analyzing because that needs follow-up time. Again, I can just reiterate what I've already shown from the previous series that have looked at this already. I don't, again, I think what we have to always consider is this is not about doing a central vein or central artery ligation. This is just a part of the procedure. So, if you leave one element away, that doesn't mean that makes the huge, the big difference. I think, as always, it's a combination of things that we need to do. And what it forces you when you follow these vessels, what it forces you to do is to do a much more precise and comprehensive operating. And I think that is part of the success that has been observed in the past. But it's never just a single element, I think, that makes the difference. So, whether you were 1 centimeter here or 1 centimeter there, I don't think that ultimately makes a difference. It's the whole package.
What percentage of your patients have received neoadjuvant treatment? Or
it's a fraction. Yeah, it's a fraction. So we don't really follow a Foxtrot protocol because we don't really believe in all of that. So for us, that the only reasons would be, people with kind of very central nodular disease or with, potentially T4 disease, T4B disease that goes into surrounding structures. But it is a very, very small fraction. So most of the patients that we operate on, they don't receive any neoadjuvant treatment for right colon cancer.
Right. Thank you very much indeed. That was a very interesting talk.
Thank you. Thank you. Thank you for having me.
The next talk is on diverticular disease, the new phase of an old malady. And Mr. Dale Vimalachandran will be speaking to us on a live platform. He is a consultant colorectal surgeon at Countess of Chester Hospital, NHS, UK. Over to Mr. Dale Vimalachandran.
Good afternoon, everybody. I hope you can hear me. Thank you very much to the organisers for inviting me to give this talk. It's a real delight, and I'm sorry I can't be there with you today. I've been asked to talk about diverticular disease, the new faces of an old malady. So the new faces I'm going to talk about over the next 15, 20 minutes or so are really around the pathophysiology, staging and assessment of the disease, treatment options, new models of pathway development and alternative models of care, and I'll just touch a little bit on the surgical approach. So it is an old malady. Diverticular disease was first discovered in the 17th century. The surgeons and the pathologists at the time didn't really know what it was. They used to call it pericolitis sinistra because it was really associated with death following perforation. It wasn't really until we got to the 20th century that they recognized it as an acute surgical problem. And surgeons in London, St. Mark's actually, commented that acute diverticulitis was now something they recognized akin to appendicitis, but in more elderly people. And it wasn't really until the 1960s when probably the most seminal work was done by Neil Painter, who essentially concluded that diverticular disease was due to the effects of fiber in the diet. And he famously weighed stool samples from patients in London, and he weighed stool samples from patients in sub-Saharan Africa, and concluded that the lack of diverticular disease in the sub-Saharan African patients was due to their high fiber in the diet. And that's really where, over the last 30 or 40 years, we've really taught clinicians and patients that people get diverticular disease because of lack of fiber in their diet. So that's probably where our new face really starts, with really more modern theories of the pathophysiology. And we now know, and there's increasing evidence, that it isn't just due to fiber in the diet. Genome-wide studies, twin studies, have shown now that there are at least 150 specific genes that are associated with diverticular disease. And most people now recognize and agree that diverticular disease is a genetic disorder. In conjunction with that, we recognize that there are dietary triggers, alcohol, smoking, red meat. There is an association with obesity, but it's unclear at the moment whether that is causative or whether it's associative, in the fact that people who are obese have the other underlying risk factors for diverticular disease. So it's not entirely clear whether obesity directly causes the disease. It's probably associated. In conjunction with the genetic formation of the diverticulum, there's also a recognition of the other systemic things, very much around the microbiome, neuromuscular interactions, are really the things that contribute then to the symptom generation. And some of that is also thought to be due to neuroplasticity and sprouting of nerve fibers. So suffice to say, there's a lot more to the pathophysiology than Neil Painter's original dietary fiber concept. So I just want to talk about the spectrum of disease, and this chart really displays really how we might classify diverticular disease, starting with asymptomatic diverticulosis through to symptomatic disease. And there's very much now a recognition that symptomatic disease is either diverticulitis, which can be complicated or uncomplicated, and I'll come on to that later in the talk. Or then we get symptomatic uncomplicated disease. And this is the spectrum of disease that probably has an overlap with irritable bowel syndrome. And it's recognized that this symptomatic uncomplicated diverticular disease is very much the thing that we see, certainly in the UK, with patients who come to clinic with recurrent bouts of pain and associated symptoms. So typically, patients with symptomatic uncomplicated diverticular disease display frequent attacks of abdominal pain, often with an abnormal bowel habit, but they don't get the associated systemic inflammatory changes that you might see in acute diverticulitis. Paddy O'Dwyer up in Edinburgh did a long-term longitudinal study a number of years ago now with patients with symptomatic uncomplicated disease and has demonstrated, like others, that the actual risk of developing acute diverticulitis or furthermore to develop the need to go acute surgery is actually quite low. So these are patients who very much sit a bit like chronic IBS with recurrent symptoms, and the treatment of this can be very difficult. There's not a lot of large-scale studies investigating how we best manage these patients. The evidence that is out there does have mixed findings for the use of probiotics, rifaximin, an antibiotic, and mesalazine, an ASA type agent, have all been used with varying degrees of success. But we absolutely recognize that these patients usually have a very poor quality of life. So I think further work is needed in this area, but there's an absolute recognition that this is probably a distinct entity from the patients we as surgeons might see in the emergency room with acute diverticulitis. Interesting when you come to looking a bit more into staging symptomatic uncomplicated diverticular disease. Whilst we again surgically will typically stage acute diverticulitis with CT, there's been a lot of work, particularly from the Italians, using endoscopic staging of the disease, and the DICA score is a diverticular inflammation and complication assessment score that is basically used endoscopically to look at the number, the size of diverticulum and the presence of inflammation. They've gone on subsequently to combine this endoscopic assessment with fecal calprotectin, and are starting to show that the combination of fecal calprotectin with the endoscopic classification can be predictive of those patients that might develop acute diverticulitis in the future. So there's definitely a progression for a small proportion of patients who will progress from that symptomatic disease through to acute diverticulitis. But again, as you can see, these papers are really only published within the last 12 to 24 months. So it's very much an evolving field. So I just want to move on now to complicated disease, because that's something probably we as surgeons probably spend most of the time treating, certainly in the acute setting. The first thing to say with acute complicated disease, it's increasing. The bar chart there on the left is from the UK. This is courtesy of David Humes, who's at Nottingham, who's done a lot of work epidemiologically with diverticular disease, and like many others around the world, has shown that we are seeing significant increases. So in the UK over the last decade, we've seen a 55% increase in emergency admissions. And in particular, we see that increase in young patients and female patients. There was a study done by Omar Faz and others in London about 10 years ago now, retrospectively, which looked at a cohort of diverticular disease patients and quite starkly showed that the 30-day mortality for patients who are admitted with acute diverticulitis is around about 5%. That doubles if they've undergone surgery, and then triples more so about 1 year later. And looked and assessed that there was a surgical intervention rate of around about 16%. And as you can see there, very high readmission rates. So in terms of a burden to society, this is an increasingly common problem. There's been some healthcare economic studies in Europe and in America. In America, the cost of diverticular disease to the healthcare, to the government, is estimated to be over $1 billion a year. So it's a big problem. It's increasing, and it has a significant health resource problem. And these are particularly young patients who end up not being able to work or having lots of time off work. This study was done, again, a number of years ago. It was a retrospective study of international data sets looking at the management of patients with acute diverticulitis, and it compared 3 large cohorts in the US, England, and Australia. And what you can see from the chart there on the right is that there was significant variation in how different healthcare environments treated diverticulitis. And you can see that the operative intervention rate varied, the operative inpatient mortality rate varied, the use of percutaneous drains varied from about 1% to 10%. So there does appear to be significant variation in both the treatment and the outcomes with acute diverticulitis. So that I'm just going to give you a little bit of update on the study that you may be aware of, and that prompted us to run Damascus, which was a global study looking at the management of patients with CT-proven diverticulitis or who underwent emergency surgery for a diverticular complication. And we really wanted to now prospectively determine whether there really is a difference in the management and of outcomes of patients both within countries and both across countries. We ran it in 248 sites across 30-40 countries, including Sri Lanka. So I'm very grateful to anyone in the audience who's contributed data. Again, as many of you know, this has also then led to the east of Damascus, which has been a study looking particularly at Eastern Asian countries. Again, perhaps trying to explore that difference genetically with patients who might have a slightly different spectrum of disease. And just to give you a few headline charts, we, again, have been able to demonstrate that significant variation. The top there shows the rate of the variation in patients who are managed in an ambulatory fashion. I'll come on to that in a minute, but you can see it varies from around 4% to as much as 60% of patients who are managed in an ambulatory outpatient way. The use of oral mesalazine, for example, again, varies significantly between geographical regions. Rates of surgery, uses of percutaneous drain, permanent colostomy formation. So I think our prospective data of these 6,000 patients has really confirmed some of the retrospective findings that there still remains significant variation in how we manage patients with acute diverticulitis. Just a quick word on how we establish the diagnosis with acute diverticulitis. There are lots of guidelines. There's probably at least 15 to 20 different national and international guidelines on how to manage diverticular disease. All of them really are based on the seminal paper by Edward Hinchey, who was a radiologist in the US in the 70s, who described the Hinchey classification. And there have been a number of adaptations to that, but most people now recognize some form of Hinchey classification, which really segregates the disease into an inflammatory phlegmon, some associated paracolic or distant abscess through to free perforation. But obviously, free perforation in terms of purulent or feculent peritonitis is something that's only really going to be established at surgery and can't always be established at CT. And pretty much most guidelines would absolutely say a routine set of bloods, including CRP, but pretty much a CT scan is the gold standard for establishing the diagnosis of acute diverticulitis. I want to just talk a little bit now through some proposed treatment algorithms of how we might manage acute diverticulitis. And I've really split it into, as I did before, acute uncomplicated disease and acute complicated disease. And there's now a recognition that patients with acute uncomplicated disease who have no significant systemic features, who are therefore classified as low risk, are a group of patients who we can probably manage in an ambulatory manner, and indeed can probably manage with simple pain relief only. The basis for this pathway and others now has really been probably these two seminal studies from Scandinavia. The Scandinavians have probably done the most work worldwide around diverticular disease. And the two big studies, the AVOD study and the Diablo study, were really looking at whether uncomplicated disease can be managed without antibiotics on the basis that this disease is sterile inflammation rather than infection. And both these studies quite clearly showed if you hold antibiotics off in these patients, it is safe. The recurrence rates are no different. The complication rates and the acute surgery rates are no different between those two groups. These studies have now reported out to 10 years, and they've led to a number of meta-analysis and systematic reviews, which have all confirmed that it is safe to hold off antibiotics in acute uncomplicated disease, and you can achieve a low complication rate, a low recurrence rate, and low hospital stay, as you can see in these forest plots, which are meta-analyses of a number of papers, including the Diablo and AVOD studies. So on the basis of these studies, a number of groups have now started to develop ambulatory pathways and analyze their data. This flowchart was a suggested protocol from a French group, and the key factor there is, again, similarly to that initial algorithm I showed you, they took patients with uncomplicated disease that were stable, that didn't have any significant systemic features, so they looked at the CRP, they weren't immunocompromised, and showed in this cohort of patients, only a small group of about 100, but showed that you can achieve a satisfactory outcome of around about 75%. And for many hospitals who have significant overload of patients at the moment, in the UK, we have significant problems with a high volume of patients coming into hospital. The ability to manage patients in an ambulatory fashion is absolutely critical. And this has really led GIRFT, which is our Getting It Right First Time platform within the NHS, to develop similar pathways now. And this pathway was only developed in the last few months, which essentially describes the ambulatory management of patients in the UK who present with acute diverticulitis. And again, essentially follows that same process, checking whether the patient's systemically well. If it's uncomplicated disease, then manage them in an ambulatory manner. And as you can see in the top right there, consider a no antibiotic prescribing strategy. So what does this look like in everyday practice? As I've sort of described, early CT, ambulatory assessment, constant reassessment is the key. Clearly, you have to have a mechanism to bring patients back. We tend to use same-day emergency care type centres in the UK to reassess these patients. And if we do this, we can probably avoid hospital admissions in around about half. Now, I put the arrow there about how we implement research findings, and we find this across all aspects of research. And despite the studies and the meta-analyses showing that antibiotics can be safely withheld, again, this is just a bit more data from Damascus, and you can see here, and Damascus was run from 2020 to 2022. Despite that evidence, 98% of patients with ambulatory managed diverticulitis and therefore uncomplicated were given antibiotics. So, despite the fact that we know that most of those patients don't need antibiotics, we are still over-prescribing. And similarly, when they came as an inpatient, again, nearly every single patient had antibiotics. So there's a lot of work to do between implementing research findings and the publication of trial data. I just want to move on to complicated disease now. This is a little bit different. Really, when we look at complicated disease, the sort of treatment decision makings around abscesses and around fecal peritonitis or purulent peritonitis. So a lot of data and a lot of guidelines about what we do with abscesses. Our group a number of years ago did a systematic review and meta-analysis of what to do with abscesses. The key decision making really for many is which abscesses need a drain, which ones need surgery. Most guidelines now would suggest that the patients are stable abscess can probably be managed with antibiotics. Abscesses that are a bit larger probably need a percutaneous drain. I think my own personal reflection of this is absolutely that is a reasonable policy, but I'm always concerned that large abscesses, any of the worrying features on the CT may represent other pathology. And I would certainly offer a word of caution that if you do this, you have to follow up, assess these patients, and you have to beware patients that fail to settle quickly or have multiple readmissions, because it's not uncommon that a recurrent diverticular abscess is actually a localized perforated tumor. Just a slide on laparoscopic lavage. I think mostly the surgical community have put this to bed now. As many of you will know, there was a real vogue about 10 years ago for laparoscopic washout of purulent peritonitis. There was a number of large studies, again, from the Scandinavians, the Lady study, the Scandiv study, and Delilah study. And essentially, they all showed roughly the same thing, in that, yes, you can do it. Yes, you avoid stomas, but the recurrence rate and the return to theatre rates are high. I think some people are probably still doing it. And I think if you do it, the advice is it has to be in a carefully selected group. It has to be with full counselling with the patient to explain that there is a high risk that this will fail and that they will avoid going back to theatre. And certainly it wouldn't be something you would consider in someone who has established organ failure, who has a significant underlying immunosuppression or significant comorbidities. So what about fecal peritonitis? I think for patients who have established fecal peritonitis or who are unstable, there isn't really any debate. They need urgent surgery, they need resection of the disease, and they probably don't need anything else other than an colostomy. There are a few other things to debate, and we'll come on to them in a second. I guess one of the things just to talk about, certainly when we do with our surgical trainers, is how you might technically do that in the unstable patient. Generally, my approach is keep it simple, and we'll come on to, again, some of the work that's now coming out of the US and Europe about damage control surgery. But essentially, my approach is to really staple above and below the perforation, leave the IMA alone, because if you are going to go back and reverse that end colostomy, you really want that TME plane left undisturbed. So really, it's just a matter of just essentially trying to exteriorize that segment of bowel. Often the hard bit is actually taking this, is actually raising the stoma. Getting this perforation out is usually quite straightforward, but if it's an obese patient with a shortened mesentery, actually some of the difficulties are around raising the stoma. And again, we'll come on to that with the concept of damage control. Also the staple line, and definitely if you can, tack it to the abdominal wall, because it makes that subsequent reversal that much easier. Sometimes that distal end is very edematous and friable, and sometimes you just have to leave a Foley catheter in transanally to try and decompress the system. Some patients do end up needing the TME, particularly if you turn out and find there's a tumor there, but sometimes the disease is actually quite distal and you end up having to take quite a lot of rectum out. Often you do find that actually the perforation is a loop of sigmoid colon that's folded over and stuck down onto the rectum, so it doesn't need a TME, it just needs that sigmoid leap fracturing off the top of the rectum. So just a little bit of a discussion on damage control, because it's a concept that people are starting to discuss. So Pat Siller and the group in SAGES in the US and the rest of us are starting to talk about the possibility of damage control surgery for stable patients. So this is the concept of doing the resection to essentially close off the perforation as you would in a damage control operation, but then dropping everything back in and returning the patient to the intensive care unit so they can be stabilized. And Ken Boffard, who is one of the sort of trauma surgeons in South Africa, normally describes that damage control surgery shouldn't take any more than an hour, because once you get past an hour, you start to get the patient becomes cold, they become coagulopathic and acidotic. And similarly with diverticular disease, if you're taking more than an hour because you're struggling to mobilize the colon or create a stoma, then the patient's going to start to become sicker. Now, clearly damage control has a role, but you do need a healthcare system or a team that is going to be able to ensure that continuity of care, which is the key challenge of who's going to take that patient back to theatre the next day. But it's certainly an evolving concept. It's important to note that time to intervention is important. And this was a large-scale study from the US looking at patients who went to theatre, and it looked at the association between 24-hour delay and mortality rate. And with fecal peritonitis, what they showed is for each day you delay, you increase the rate, the mortality rate by as much as 30%. So if patients have got fecal peritonitis, they need to get into theatre very quickly. Obviously, outside of fecal peritonitis, in a stable patient, purulent peritonitis, then really the question is about primary resection and anastomosis. And this was the other half of the Lady study. And again, it showed, like many other studies now, that if you do a primary resection and anastomosis, you obviously reduce the long-term stoma rate. And there's also a suggestion that you can actually reduce the incidence of incisional hernia. The incisional hernia has probably got other factors, I suspect, and we suspect that this incisional hernia and diverticular disease probably share some underlying genetic factors. But suffice to say, we probably need to be considering primary section anastomosis more in stable patients who have minimally contaminated or purulent peritonitis. Just a slide on imaging, and again, a lot of our juniors will often ask which patients should have a follow-up endoscopy after acute diverticulitis. And again, lots of predominantly retrospective studies, but some prospective studies that have really all shown roughly the same thing, that after an uncomplicated attack, the risk of an underlying cancer is very low, and it's probably less than 2%. And so what we tend to recommend, if it's uncomplicated disease, there are no other worrying features such as any local lymph nodes, any shouldering, then routine endoscopic assessment is probably not required. I'm often asked quite a lot whether there's a role for fit testing after an acute attack of diverticulitis. There isn't any data out there in the community at the moment regarding this. What we don't know is whether adenomas are simply associated with the underlying etiology of diverticular disease, but there certainly isn't any evidence at the moment to suggest that diverticular disease is a risk factor or precursor to adenomas. So the features are probably an association with a common underlying etiological factor. Clearly, if patients have had complicated disease, such as abscesses, localized perforations, we would recommend endoscopic assessment. And then finally, just to talk about the role of elective resection, and again, back to the Scandinavians who have run a number of studies. The direct study was the big study that was published a couple of years ago, and more recently, the laser study published this year. And both those studies essentially saw very similar things. There is a role for elective resection. If you do it, the quality of life is improved in patients who undergo resection. However, the complication rate is relatively high. And all the studies, there's quite a lot of crossover as well from the patients who are managed in the conservative arm through to the operative arm. These are often quite difficult studies to recruit to, so the numbers are quite low. But what study data we do have at the moment does suggest that if you carefully select your group, if you counsel a patient about the risk of complications, then quality of life can be improved with elective resection. And then finally, just to touch on technical progression, I think it's important just to highlight the things that are coming. Obviously, in our last talk, we have seen some really impressive videos around robotic surgery. And clearly now, with regards to elective resection, a lot of work around, obviously, first of all, laparoscopic surgery, now onto robotic surgery, and increasingly people are pushing the envelope. And the most recent now, natural orifice surgery, and again, robotic natural orifice surgery, small pockets around the world of units that are performing minimally invasive surgery to remove diverticular disease in the elective setting. But suffice to say, this surgery can all be done in a minimally invasive fashion for the most part. So just to summarize the new faces of this old malady, the pathogenesis of diverticular disease is almost certainly much more complicated than we originally thought. We need to consider more proactive treatment of symptomatic uncomplicated diverticular disease, and more research is probably needed in this area. We need to, like many other colorectal conditions, consider more tailored investigation and imaging. There's definitely a need to increase the number of patients that we manage in an ambulatory manner, and we have to really start to think about how much antibiotics we're using in this patient population. We need to consider more the use of primary anastomosis in stable but perforated disease. There is growing evidence for elective resection to improve the quality of life of patients, but again, more data is probably needed to support this. And there's probably enough data now to suggest that routine endoscopic follow-up after an uncomplicated attack is probably not required. So thank you very much for listening. I'm happy to take any questions.
Have you got any questions for?
Hi. Dale, this is Vasanta here. And can I know, it's all about complicated diverticular disease. I think we have no problem of managing that. And suppose if we find diverticulosis incidentally, and if they are asymptomatic, is there a way that we can reduce the progression of this disease into complicated disease, other than the lifestyle modifications?
Yeah, it's a really good question, isn't it? Linking, you sometimes see patients, don't you, who have extensive diverticulosis but have minimal symptoms. And I think that the answer to that question really lies around symptomatic uncomplicated disease and the evidence to look at really dampening down that inflammation. So I think if you have patients with extensive disease, I think starting to look at that endoscopic assessment to quantify that disease. If they have high levels of inflammatory markers, so fecal calprotectin is high, then perhaps using mesalazine, rifaximin, probiotics are the things that we would look at in addition to lifestyle changes. But of course, if it's obesity and poor lifestyle that's given them diverticular disease, unfortunately that's already happened. So lifestyle changes won't necessarily solve all the problems. And again, some of it may be genetic. So I think it's really about disease assessment endoscopically and considering the use of anti-inflammatories, probiotics and antibiotics selectively.
Ideal. Pramod here. Thank you very much for that wonderful talk. Do you practice in the UK administration of fecal softeners, antispasmodics, and like Bifilac in a routine basis for those who you detect with diverticulosis? Or is it just for the symptomatic patients?
Yeah, typically just the symptomatic patients. We definitely recognize a cohort of patients who often, if they have bad diverticular disease, get sort of fecal loading and constipation proximally, and often will get pain. So for those patients that are symptomatic from that, then yeah, we will use fecal softeners and Buscopan, but it's on a selective basis rather than routinely.
Dale, there's a question from me. How do you manage perforated diverticular disease, abscesses and all, with minimal access laparoscopically?
Yes, we try to where possible. I think the use of minimally invasive surgery in the emergency setting is still something that is evolving. In the UK, we have a trial that's running at the moment, LACES2, which is run out of Leeds, which is really trying to develop greater use of minimally invasive surgery. So in my own practice, if a patient is stable and is otherwise favorable, then we will attempt minimally invasive surgery. But clearly, sometimes it can be technically challenging. We also, within the UK, also have a lot of units that run with an emergency surgeon type model. So these may be not specifically colorectal trained. And similar to the US, where I found when we've worked with them, actually a lot of the urgent surgery is carried out by an emergency surgeon rather than a colorectal surgeon. So that sometimes reduces the chance of minimally invasive surgery. But certainly there's a desire in the UK to try and increase the number of minimally invasive colorectal emergency surgeries we're doing.
Thank you very much for the very informative lecture, Mahanama. I would like to ask that you said the primary anastomosis has better outcome, because we have to do primary anastomosis sometimes because it's very difficult to do colostomy also sometimes. So do you resect the entire diseased bowel, or you do the segmental resection and anastomose there, you find where there is no diverticulae and then anastomose at that point?
Yeah, no, that's a really good question. And, I think, as you know, you'll have different patterns of disease, won't you, in terms of whether you can get diverticular, clear the disease. There's two margins to think about. There's the distal margin and the proximal margin. Most guidelines and evidence would now suggest that your distal margin should be the top of the rectum, where there should be no diverticulum. So typically always resect down to the top of the rectum. If you can get proximal clearance, and often with perforated disease, it is often just isolated or minimal number of diverticulum. If you have got pancolonic diverticular disease, then typically you end up having to make an anastomosis just simply in a segment of bowel where there's no diverticulum present. So I think it's the distal margin you can control quite easily. The proximal margin can be difficult, and sometimes you just have to choose an area that is free of disease, but accept that there will be some more proximal diverticulum. And certainly, indeed, in Damascus, we have seen patients who have undergone surgery for diverticulum in an acute setting have actually come back in, and presumably that's because some of them have had flare-ups from that proximal disease.
Thank you very much.
Yeah, in the interest of the time, to keep up with the time, thank you very much, Dale, for the very useful and informative lecture. And we will go to the next speaker, Mr. Janindra Varusuvitana, who has come here in person to deliver his lecture. He's a consultant colorectal surgeon, St. Mark's Hospital, London.
Thank you very much. And as always, it's a great pleasure to be back here and talk to you all. So today I'm going to talk to you about the surgical decision making in ulcerative colitis, who, when, and what. Now, if we look at emergency ulcerative colitis, when a patient gets admitted to hospital for ulcerative colitis, there are a few objectives of the medical treatment for ulcerative colitis. So that is to save the colon, try and induce remission, and then to avoid surgery. And there are various things people talk about: the risk of pouch failure, the function, the risk of a permanent stoma. And some of these are driven by the gastroenterologist, some of these are driven by the patients, and there are various different views that are taken by different people based on their general feelings. And if you look at this, you can see that there is a general sort of trend, or there was a general sort of trend of exposure to various medications, and in particular the bringing in together infliximab and all of the other biologics and completely new drugs available. There is this way of exposing people to more and more medications. But have we really reduced the colectomy rate? So if you look at these data from Canada, you can see that the total colectomy rate sort of dipped down a little bit, but are coming back up. But the difference is that actually your emergency colectomy rates are quietly going up. So actually, the reality of the situation is your colectomy rates are not dropping from the late 90s, but what's happening is that you're doing less of the elective ones and more of the emergency ones. So we've got various different treatment, we've got various different decision strategies in how we really work out whether patients are to have elective or to have emergency operations. So when they're admitted to hospitals, we'll look at things like how many bloody stools do you have, what's your pulse, temperature, hemoglobin, CRP, SI, etc. You can also use endoscopic, and usually it's flexible sigmoidoscopies to assess what the colon looks like and then see how you go. And you can see that depending on the frequency of the stool, the dilatation, whether they have hypoalbuminemia and so on and so forth, you can sort of give a general idea as to what that patient's risk of colectomy is going to be. Now, it's all well and good to have these scoring systems, but remember that these are patients who've gone through various different strategies and refuse to actually have surgery sometimes. So they've got to understand what the surgery is going to be about. So a percentage of these patients will be admitted and they will be discharged because they'll respond to steroids or whatever. So our job as surgeons is to make sure that we see them on a daily basis, that we educate them. And I always say to people, it doesn't really matter if you don't have surgery. You have to understand what the surgery is about, because if you do need surgery at a later date, then this is going to be a useful information process. So a really sick patient is never really going to understand what is going to be needed, because their mental state is not at the right place to understand all of the information that we give. So what you don't want to also do is you don't want to flog a dead horse. So you don't want to keep people going through medication and medication and medication. You've got to reach a point, because you can actually have a significant mortality associated with a colectomy if you really make someone incredibly sick. So do we think it's safe to do a total colectomy and do a single stage pouch? And actually a lot of these data are quite old, and a lot of these data are before the biologic times. And you can see that the risk of pelvic sepsis varies depending on the organization you look at. But the proponents would argue that it was fairly safe. But actually, and I'll come back to it in a little while, but if you look through the data now, it is very rare for most people to actually do a single stage pouch, because the medications we use and how sick the patients are slightly different as well. And what we really want to avoid is pelvic sepsis. Using this algorithm, you can see that if you have an anastomotic leak and pelvic sepsis, your pouch failure rate over the long period of time will be quite significant. You can also have a little bit of pelvic sepsis but no anastomotic separation and have a much reduced pouch failure rate. So what you really want to be very careful about that anastomotic separation and pelvic sepsis. And of course, having sepsis per se will severely impact your pouch function as well. Now, remember the medication side of these things, because it's not only that you have an incredibly sick patient in ulcerative colitis in the acute setting, but they're also going to be on significant immunosuppressive medications, steroids being one of them. And your risk of anastomotic leak, especially if you're over 20 milligrams of oral steroids, is quite significant. So this works for both Crohn's and ulcerative colitis. We also know that if you have infliximab, the risk of infectious complications are higher in patients who have pouch. Now, I'm not entirely sure that it's infliximab that causes the problem. I think it's got to do with the fact that these people are incredibly unwell, and that at a time of doing the surgery, they're incredibly unwell, and therefore that's what drives you from not wanting to do a pelvic operation on these patients. So on this basis, I think that it is probably very, very reasonable to think about performing a subtotal colectomy in these patients. And it also has a massive benefit, because it'll give you a good answer in terms of the pathology. Is it indeterminate colitis or is it Crohn's? And that's another discussion. But it also gives the people an understanding of what it is like to live with an ileostomy. And they can make their decisions of where they go much, much later when they're well. And this is an interesting concept, because if you look back about 10 years ago, and there's no data for this, but this is very anecdotal and listening to my patients, it was almost impossible to find a youngish patient who would say they wanted to live with a permanent stoma. But social media and pretty much all of the things that go with it, and a general feeling of knowing that there are a lot of people who actually have either a stoma or they live under those circumstances, means that the paradigm shifted a little bit. There are quite a few people, and still the majority would not want to have one, but there are still quite a few people who would now say that they don't mind having a permanent stoma, or they will delay having their pouch surgery, or they will just ask for a proctectomy. So paradigms will shift depending on what people understand as well. And then the emergency colectomy. I think planning this is really important. You don't want to end up doing it at 2 o'clock in the morning if you can avoid it. And there is you have a window as well, because it's very rare that you really need to do it as an emergency. Do we do it laparoscopic or open? Well, I would say it's always better if you can do all of them laparoscopically. Of course, there are a few technical tips. For example, you want to avoid the splenic flexure last, because if you think about ulcerative, you want to do the splenic flexure last, sorry. If you think about ulcerative colitis, most of your disease is going to be on the left-hand side, and it is the right-hand side of your colon that's going to be dilated. And that watershed area at the splenic flexure is where you're going to get the dilatation. So if you fiddle with that area first, you're more likely to run into trouble. So it's that sort of stuff, and I'll come to that. And of course, managing the rectal stump is also an important concept. So we've got to have good timing and conversation with the patient. We want to avoid a perforation or toxic megacolon, and if we can, do it as a semi-elective procedure. Laparoscopic or open, I think it's best done on the expertise. And I really think that it is really important that these procedures are done by colorectal surgeons who and done laparoscopically where possible. And the problems will happen if you've got dilated small bowel and there is a reasonably high conversion rate. As I said to you, we'd leave the splenic fracture to the last. We try and avoid handling the colon where possible. And you can do a combination of either a closed colonic dissection or a vascular dissection, but I tend to leave the IMA in situ. And that's sort of how it's done, so that you have vasculature of the rectum. The hardest part of these operations are the middle colics. What I tend to do is do this much like you would do a cancer operation, because it is the safest way to avoid running into trouble at this middle colic level. And you can essentially come from the medial approach and go all the way into the lesser sac, and then take the omentum down and have the middle colic vessels well and truly exposed. It reduces, it reduces the impact of bleeding. Doesn't like to fast forward. It reduces the impact of bleeding quite considerably if you separate the middle colic vessels. And essentially that's what you end up with. In terms of the rectal stump, do we exteriorize it or close it? And if we exteriorize it, is it subcutaneous or a mucous fistula? Are we going to have an intraperitoneal or an extraperitoneal closure? And there are no clear guidelines, and we don't really know which of those patients should we give a mucous fistula to. And mucous fistulas have their issues as well. But also remembering that perforation of the stump can be associated with significant morbidity. And you can see here that if you had there are people who leave a very short intrapelvic stump, and that's because they feel that the shorter you leave it, the less likely you are to have problems. I think this gives you massive issues when you want to do a pouch at a later stage, and I really recommend that you don't take it down as short as possible. And you can see from the data here that the pelvic sepsis rate doesn't really change. Placing it subcutaneously, about 30% of these spontaneously perforate anyway, causing a mucus fistula. So I tend to personally put my mucus fistula just next to this stoma. And this is also done by my colleague Yves Panis in France. Together we looked at our data, and you can see that we didn't have any intra-abdominal sepsis that was related to the stump. And I think in conclusion for this part, as a surgeon, we should see the patient early and monitor, plan the emergency colectomy to reduce the risk of an already sick patient, and laparoscopy is very feasible, but think about safety first. But I would still say look at laparoscopy fairly carefully and consider a mucus fistula in patients where there is a high risk of perforation. Now, in terms of the pouch, and I'll be very quick on this one because we're going to run out of time very soon, there are a couple of things I want to think about. The first is the steps to getting the appropriate pouch length. Well, if you make a pouch, or at least temporarily form one, and you can pull it below the inferior margin of the symphysis pubis, depending on how much of it you can pull down, you know what the percentage is that you are going to reach the dentate line. The blood vessels are also really important, and this is why people say try and preserve the ileocolic vessel, because if you want to lengthen the small bowel mesentery, you can actually do that by dividing the ileocolic at a later stage, and that sort of tends to stretch things. We also have the method of transilluminating it and then opening up those little windows so that you can straighten out the mesentery, and that also gives you about 1 centimeter or so. There are a couple of things that we call the Phillips points after Professor Phillips, who came up with this suggestion at St. Mark's Hospital. And this relates to actually the point where the stapler always cuts before it staples, and there are tiny little areas where you can actually put your forceps through, and those points can be other leakage points and should be secured. And in the laparoscopic side, it is really important to make sure that you have, especially in the female, the vagina separated to avoid the rectovaginal fistulas. And this is again another anecdotal comment from me, but I think since we started doing things laparoscopically, we get less rectovaginal fistulas because you get a really good vision when you actually anastomose the pouch to the anal canal. Do we do 3-stage pouches? I have to say that in my personal experience, I do less 3-stage pouches. Now I tend to do more 2, and I'm talking about the modified 2-stage where we do a subtotal and then do a pouch without an anastomosis. That's probably because there is no real need, given that only about 10 to 15% of those patients actually will need a stoma. You can actually manage those leaks, especially by the use of things like the endosponge, and Willem Bemmelman from the Netherlands and his group showed very clearly about the benefits of using the endosponge. And we know that if we detect the leaks early, and this is my argument for doing a modified 2-stage, is that you have to detect the leaks early, but if you do detect the leaks early, you can actually have good pouch outcomes. It's the delayed leaks that tend to be the problem. Is selective defunctioning an option? I think it certainly is. You can see that from the Dutch group again, they had a group of patients that had primary defunctioning, or about 6% of those patients only needed secondary defunctioning within the two groups. And there was no difference in the leak rate between the primary and the secondary groups. But also remember, ileostomies in their own rights are not associated with complications, and a lot of them, because the ileostomy is much higher up in the pouch, is also associated with high output stomas and leaking bags and so on as well. So in my approach, I think the best strategy for a restorative proctocolectomy is a modified two-stage operation, and I think the evidence is fairly safe. And I think it's highly likely that we are defunctioning too many pouches, and that's why I tend to do the modified two-stage at this stage. But it is incredibly difficult to convince people about this, because there is the fear that we're really being too dramatic. But again, like everything, it's not about doing the anastomosis and then walking away. It is about making sure that you check those patients. So we regularly do their CRPs in the first 3 days, and if things are starting to not point in the right direction, we will then CT scan them and then decide what we do from there. Thank you very much.
Thank you very much, Janindra. Very interesting talk. This is open for questions now. May I ask a few questions? You said medical treatment just delaying surgery. In our setup, we do surgery when medical treatment fails, and when there is evidence of severe dysplasia or complications. As you said, sort of in practice, do you do early surgery in patients with limited ulcerative colitis? I'm not talking about pancolitis. Before medical treatment fails?
There are a couple of things. There are 3 groups of patients who need surgery. This subject is a very long subject, so it had to be cut short but there are 3 groups. There's the acute severe colitis, there's a chronic colitis, and there are dysplasia patients, as you said. You have to reach a threshold about where you think the medical treatment, and again, I'm dead against the use of the word failure, because I think that's really wrong from the patient's point of view to say that medical treatment failed and that surgery is then a last resort. You have to find a balance in this whole thing. So we tend to use the word refractory, which means that they are just not responding to the treatments. And that's where your chronic patients come in. They will carry on going to the toilet 30 times a day, but they will reach a point where they will say, okay, I think I'm ready now. And you have to wait for that period in time. In the acute patients, and that's the ones that I was referring to before, you cannot flog them beyond a certain point, right? The acute patients, because one of the problems is that there is a high mortality. If you go back in history and you look at the mortality rates associated with surgery with ulcerative colitis in the early 1900s, it's incredibly high. And that was also because the patients were sick and they didn't have the same level of medications and so on and so forth. So when it comes to the decision-making process, you have to have a joint approach. This is where the physicians and the surgeons have to work together. You cannot, under any circumstances, in my opinion, say that we will wait till the physician says they can't go anymore. You have to have a joint approach. So we would see those patients on a daily basis, at least myself or the team, and then have a conversation. And those patients are also discussed regularly at the IBD MDTs. So that's the important point.
Thank you very much.
Then anastomosis and managing the rectum with local treatment rather than going for pouch surgery.
Okay, so the Scandinavians have done that, but when we looked at the UK data and the Danish data, you can see that, sorry, the Swedish data, you can see that the Swedish tend to operate on patients a lot earlier than we do in the UK. I have to say that in my personal experience, anyone that I've done an ileorectal anastomosis in has never really done very well. That's number one. Number two is I would never recommend you do an ileorectal as the first operation, because again, don't forget that those patients are sick, right? Yeah, okay. As a second stage, you have to make sure that in that period that you're, you have a 3-month, 6-month period where you wait for the second stage, that the rectum is well controlled with the topical treatments, and that on sigmoidoscopy, at least the rectum looks all right. But I can guarantee you that the very few that I've done that looked all right, they always fail. So I don't feel very confident about it. But this, if you ask the Swedish right here, they would say completely differently.
Thanks, Janindra, for that wonderful presentation. In the interest